Thank you so much. So, as Dr. Vamsi Krishna introduced, I am going to talk about majorly about picking the correct mutation. So, in a way, talking about PIK3CA mutations. So, I'm very grateful for the opportunity, and I'll try to keep it very short and crisp, and so that we can have a discussion after. So, majorly, I'll be talking about the biomarkers, genetic alterations in breast cancer, PIK3CA mutations, ESR1 mutations, and certain laboratory specifications which are important around this. So firstly, breast cancer, as we all know, it accounts for almost 14% of cancers in Indian women, and it is reported that every 4 minutes an Indian woman is diagnosed with breast cancer. It is the most common type of cancer. According to Globocan 2020 data, there were 17,836 361 new registered cases and 90,408 reported deaths. So this is the recent data around breast cancer. Now, for the biomarkers, as you can see in NCCN guidelines, there are relatively, ERPR testing, HER2 testing. So in here, ERPR testing has to be done for almost all the breast cancer patient. That is kind of an initial diagnosis process. And then HER2 testing is also to be performed on all new and primary or newly metastatic breast cancers in a ASCO or CAP accredited HER2 testing guideline method. Then if you look at the biomarkers which are listed for invasive breast cancer, that is your advanced breast cancer cases, we have BRCA1, BRCA2 germline sequencing for olaparib in any kind of breast cancer subtype, be it HER2 positive, HER2 negative, or hormonal positive, hormonal negative. Specifically for hormonal positive and HER2 negative breast cancer tumors, PIK3CA mutations are coming up as an important important mutation testing, because there is an FDA approved therapy which can be given to the patient in terms of alpelisib plus fulvestrant, and definitely it is in terms of second line or subsequent line of therapy. Then you have in case of triple negative breast cancer, PDL1 expression, then NTRK fusions in any kind of breast cancer cases. Other than that, MSI and TMB for available as immunotherapy agents. So these biomarkers are to be tested before deciding on the benefit of the patient per se to immunotherapy as a treatment. After that, this is just a consolidated list of all the biomarkers that pertain. Certainly, you come across in case of breast cancer patients, which are to be routinely done in terms of getting the clear understanding of the treatment. You have ERPR, HER2, definitely protein expression and amplification, then PIK3CA mutations, which are majorly activating mutations. That is where the gain of function of PIK3CA protein happens, and incidence in Indian population is almost up to 28% specifically. Coming to ASCO guidelines, which are just very recent, they have recommended PIK3CA testing using either tissue or ctDNA by NGS. That's a very important recommendation, and in terms of tissue availability, it definitely becomes sometimes a major roadblock for when we are looking forward to test for the patient. So certainly ctDNA, that is cell-free DNA testing for PIK3CA mutations, is now recommended by NCCN and ASCO both. Then you have BRCA1, BRCA2 germline testing, PDL1 by IHC, MSI, or DMMR, and TMB and NTRK fusion. So these are the recommended ones, which are definitely as an upfront testing should be offered to the patient. Coming to germline and somatic mutations, definitely in terms of detecting the germline mutation mutations, because they are present in all the cells of the body, they are inherited, so they could just be detected with a simple blood draw. However, in case of somatic mutations, they have to be captured through testing the tumor tissue or even the cell-free DNA these days. So as we have already discussed, there are major genomic alterations which are having high penetrance, that includes BRCA1, BRCA2, TP53, PALB2, PTEN. These are all germline mutations that contribute to occurrence of breast cancer. And the somatic mutations, that is the mutations that take place specifically in the breast tissue, they include PIK3CA and ERBB2, which are majorly causing the tumor to be formed in the breast. So BRCA1, BRCA2 testing has been already, I think it's quite evident, so I will not take much of a time on highlighting that. I would just like to highlight our experience as a big big center, testing almost more than 20,000 patients now, and we have got one information, that is that the MLPA percentage in breast cancer cases, that is BRCA1, BRCA2 large deletion duplications, are not found in more than 1 to 2% patients. So as per Indian data, more of the patients are having definitely point mutation itself in the BRCA1 and BRCA2 genes. And if you look at the reason, should a family history be a contributing factor, as per our database, even patients without family history showed almost equal percentage or frequency of BRCA1, BRCA2 variants in in families where there was no cases of familial cancers before. So definitely somatic testing can capture both germline and somatic variants. So tumor testing is more prevalent these days because of the only reason. Now coming to the important topic of PIK3CA mutations. So majorly the PIK3CA molecule is present in kind of a downstream in the cell signaling pathway, where it has RAS binding sites and kinase sites and helical binding sites. The gain of function mutations majorly takes place in the exon 7, exon 9, and exon 20 region, and these are the commonly found mutations in those particular exons. Now detecting why we have to definitely look for PIK3CA mutations is because in case of early breast cancer, it is related to better disease-free survival and better overall survival. And in case of HER2 positive breast cancer cases, it is associated with lower pathological complete response rates. And in case of HER2 negative hormone positive, it is related to poor outcome and resistance to chemotherapy. That is majorly because it constitutively activates the mTOR pathway, which is downstream in the cell signaling. And the most important point is alpelisib and fulvestrant, which is indicated to treat the postmenopausal woman with hormone positive HER2 negative PIK3CA mutated tumors, which are metastatic breast cancer and have been showing progression on endocrine based regimen. Also, another important point is patients who are having double PIK3CA mutations. They are almost 4% of all the breast cancer cases, and they showed an overall survival or odds ratio of to PIK3CA inhibitor was double higher in double mutant as compared to single mutant PIK3CA. So the double mutant PIK3CA patients will have a better ORR, that is overall survival, as compared to patients having single one. So this is that same data which I just discussed. Now, when we have to test the PIK3CA mutation testing, once the initial workup for IHC is done, chemotherapy and endocrine therapy is given as per the initial IHC workup, whether it's a hormone positive, hormone negative patient. After that, if there is a progression and resistance, and also, as per the, if it is a stage 4 patient, then PIK3CA testing should be done to avert if the patient will respond to chemotherapy or not. And as per guidelines, if you see, in PIK3CA testing is now recommended as an initial workup in metastatic breast cancer patient. And if the patient has stage 4 disease, if the tumor is hormone positive and HER2 negative, and if there is a consideration that they look with the clinician wants to look for a targeted therapy, definitely there the patient has to start with endocrine therapy before, and must be showing progression on that. And then PIK3CA testing can help in better prognostication and treatment planning. So how to
Ma'am,
test PIK3CA? Yeah.
ma'am, we need to move forward.
Okay. So particularly the main test which I wanted to discuss was RT-PCR PIK3CA testing. So RT-PCR PIK3CA testing can be done both on liquid biopsy and tissue samples, and this is available with MedGenome. NGS has better results in terms of detecting all known and unknown variants. However, RT-PCR is more cost effective and has sensitivity rate, and also gives you faster results as compared to NGS. So I think as there is a constraint of time, so I will just wind it up by coming to the key takeaways. So the key takeaways is that NGS is the best choice of method for BRCA1 BRCA2 testing, and upfront testing for PIK3CA in hormone positive HER2 negative breast cancer patients is important for better prognostication and treatment planning. Both tissue testing and liquid biopsy testing can be used. If liquid biopsy is negative, then tissue testing can be recommended to avoid false negative results. And comprehensive tumor profiling in case of metastatic breast cancer can identify all the relevant alterations like PIK3CA, ESR1, CDK4, CDK6, and HER2 genes at a single shot. So it can be a one-stop solution. So NGS block preparation is a very important, crucial step for a successful NGS assay. So I think that will be all from my side. So if there are any questions, I can take those in the chat. Thank you so much.
Thank you, Dr. Charu. I think again, in the interest of time, I don't see any questions as of now, but if case comes, we will get back to you. For me, the most important two takeaways which you said, one is if the liquid biopsy is negative, please go for a solid. You do have false negatives. I think that's an important takeaway for all clinicians. And secondly, the double mutant that you spoke about, that is important, which to be honest, I don't really look at. Now that you have told me, I think we are going to start looking at these two. So
Sure,
thank you so much. Thank you so much, Dr. Charu.
Thank you so much.
And
thank you.
For the next talk, I would like to invite Dr. Satya Dattatray, who is a mentor for all the medical oncologists in Hyderabad. And he is a senior medical oncologist and chief of medical oncology at the Renova Soumya Hospital in Hyderabad. So he will be talking about a very weighty topic. His topic is quite long, discussing ribociclib real-world evidence, as well as randomized control trials and bridging that divide in over 8,000 patients. So over to